So cataract surgery has been there for almost 3 decades now in terms of photoemulsification. But there are many things that go unnoticed because we've gotten on from that fight of disassembling the nucleus to giving a good surgical outcomes in terms of vision. But find things like unknown Descemet's detachments will often turn up in your clinic, and they'll cause subclinical or sometimes even manifest good corneal edema on post-op day 1. So we decided to understand why these are happening and whether incision, either clinically and histomorphologically, manual versus femtosecond, would have any bearing on an uneventful cataract surgery purely from Descemet's detachment point of view. This was a prospective randomized clinical trial. Randomization was between group 1 and group 2, which is group 1, which is undergoing a manual incision. Second group undergoes a manual incision with a little bit of flare. The exclusion criteria was any other core diseases and a very hard grade of cataract. Standard surgical technique was performed. Group 1, which was 150 eyes, had 2.2 millimeter entry with the geometric incision, as would normally do. Group 2 had a flare or an internal flare. We would do an incision and we would flare it up internally based on the clinician's judgment with the same blade, and it was an anterior beveled knife. And group 3 was a femtosecond incision with an external entry of 2.2 and an internal entry of 2.3 millimeters. We looked at Descemet's detachment clinically, asking the surgeon whether they could see a Descemet's detachment, and using an anterior segment OCT to see at the end of 1 hour of surgery whether they could pick up a subtle Descemet's detachment. Also, parallelly, we did a histomorphological study using femto incisions and manual incisions on cadaveric eyes that were subjected to fixing and then looking at the incision morphology. If you look at the results, the grade of cataract was comparable in all the groups. The flax group had a slightly higher age bracket, but that's probably because they chose it that way. Energy dissipation was the least in femtosecond group, as is expected because the chops were pretty much done beforehand. If you look at the clinical Descemet's detachment, both the group 1, which is the manual incision, and the manual incision with an internal flare showed pretty much detachment in the clinical judgment. Also, when we looked at AIOS-OCTs, the detachment was the least when was seen with the femtosecond incision. This is just to show you a sample showing flax incision. There is slight gaping at the endothelial site and maybe a subtle detachment, but more or less the incision is organized and kept well opposed. Compare it to a manual incision where you can see the gaping is much more and the Descemet's detachment is pretty apparent. Again, this reflected again in the same thing. So endothelial misalignment was also significantly higher with both the manual incisions and was low using the flax trapezoidal incision. Although slit lamp, we didn't pick up anything. When we look at cadaveric eyes on histomorphology, and this is just to show you how histomorphology slides look, on the left is a manual incision where you can see that there is misalignment of the floor and roof because it's slid through, probably also due to maneuverability, while the femtosecond incision shows a slightly more alignment as compared to a manual insert. When we look at collagen disorganization, this is evident over there. There's more collagen disorganization using a blade as looking to a femtosecond incision. It has been shown that it is very important to keep an eye on incisions when you're doing a surgery because it's the distortion more than the size that you do. It's not a fight between 1.8 or a 2.2 or a 2.4, but the insult that you do as a surgeon that makes a lot of difference. And also sometimes incompatibly and doing a wound assisted push delivery can really spoil the incision. Surgical technique also plays a great role. So to understand Descemet's detachment, if it happens and in the hands of an early surgeon, can lead to a big catastrophe if you cause a corneal edema or do a detachment, complete detachment. And that's why it needs to be picked up. So to conclude, our study showed that Descemet's detachment does happen in as close to 80% people if you look critically. A trapezoidal configuration, while manually can be done, is not titrable, and therefore sometimes technology like femtosecond may come to rescue and give you better outcomes. Thank you.
So these studies which you did on the incisions, were they done immediately, like after how long?
So madam, we had a cooling period of 1 hour while the patient was being discharged. So once the patient's been discharged from the surgery and went down to the OP, that is when we did it for all patients. Okay. And the randomization was only between the incision because flax was not our call, whatever the patient picked up.
Okay. So how long was this observation done on these patients?
So madam, this observation is only on first post-op day. The next paper will be on long-term outcomes, but most of these Descemet's will stick back because as the endothelium pump picks up, it's going to cause a slow closure. And at the end of, say, glass appointment, which for me is 10 days, generally most patients will not show Descemet's detachment because Descemet's will stick back on its place automatically.
So if I give you a time frame of 6 months, what do you think will be the comparison between the two?
I think both will look the same.
Yeah. Right. Yeah. All right. Thank you so much.
Thank you.